Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Tiffany Hensley McBain. Today's episode is titled What's New in HIV Treatment Safety and Tolerability? Data from 2020 Conferences. This podcast is part of a comprehensive educational program on antiretroviral safety and tolerability. During this episode, Dr. Brian Wood from the University of Washington in Seattle, Washington, will discuss the latest data on weight gain with ART and ART safety during conception and pregnancy. For more information about Dr. Wood and for a link to the full online educational program, including downloadable slides specific to today's discussion, please visit the show notes for this episode. Now let's get started with hearing what Dr. Wood has to say about the latest data on ART and weight gain.
Thanks very much, Tiffany. Thanks to the CCO team for inviting me and for organizing this, and welcome everyone wherever you are logging in from. Hope you are well and appreciate you taking the time. The goal today will be to review two of the hottest topics in HIV treatment, safety, and tolerability. First, antiretroviral-associated weight gain, and then antiretroviral safety during conception and pregnancy. But let's start with this topic, antiretroviral-associated weight gain, a very hot topic, a lot of question, more understanding, I would say, based on recent data analyses coming out, and we'll look at some of those, but still a lot of consternation and question around this topic. Here's a reminder of first line or antiretroviral recommendations, first line for treatment-naive individuals. You can see here a summary of the recommended options from the Department of Health and Human Services, from the IAS USA, from the European AIDS Clinical Society, and the WHO. Excuse me, the WHO first-line regimen as dolutegravir plus TDF, XTC, which is used in abbreviation for FTC or 3TC, and then from the European AIDS Clinical Society and the two United States Guidelines Recommendations Group, you can see that the first line recommended regimens largely align, largely favor the second generation, if you will, integrase strand transfer inhibitors or INSTIs, bictegravir or dolutegravir, plus various combinations of NRTIs, those being TAF or TDF with 3TC or FTC, or the most recent addition, dolutegravir 3TC as two-drug initial therapy. The asterisk there because there are a lot of caveats around using that regimen for initial therapy based on viral load, whether you have resistance results and know that the two agents in that combination are active, and very importantly, whether you know someone's hepatitis B status or not. You can see raltegravir, a earlier generation INSTI, also as a recommended option. In my experience lately, not being used nearly as much as the others for first-line therapy. And then what's come out in the last, I'd say year or two is more understanding of weight change that happens with these various options. And as you probably know, there has been a consistent association with greater weight gain, especially in the first 1 to 2 years. And we'll look at this in more detail with integrase inhibitors compared to other classes, especially with dolutegravir, bictegravir compared to other INSTIs, and with TAF compared to other NRTIs. Now, as a foundation for this discussion, we'd like to show you a little bit of data from this analysis. This publication, led by Paul Sachs and colleagues, was a pooled analysis looking at weight gain associated with ART, various HIV-related factors, various demographic factors over time, all for treatment-naive individuals. And if you're interested in this topic, I would really encourage you to take a closer look at this publication. There's some very, very rich illustrative figures. We're showing some of them to you here. So in this analysis, which combined had over 5,600 individuals starting first-line ART, you can see here on the far left graph, this is mean weight change over 96 weeks. You can see here the individuals receiving an INSTI as their first-line regimen gained more weight than those who received a protease inhibitor and more weight than those who received an NNRTI. And you can see here the overall mean somewhere in the 2 to 3 kilogram range. In the middle graph, you can see that of the INSTIs, individuals received first line, more weight gain associated with bictegravir or dolutegravir compared to cobicistat boosted elbictegravir. And then notably on the far right in the NRTI chart, you can see greater weight gain associated with TAF as compared to abacavir, as compared to TDF, and then cidobutene at the bottom. In the NNRTI class, rilpivirine associated more weight gain than efavirenz, so it's not just with the INSTIs and the NRTIs, and we'll come back to why I think that may be important, and also more weight gain associated with certain demographic factors, with being female sex at birth compared to male sex at birth, being non-white compared to white, and other trends that tend to mirror or reflect general trends of weight gain in the overall population, including in individuals without HIV. So very rich study here, lots of data and a good foundation for talking about this. The other very notable trial was this one called ADVANCE, which was a randomized clinical control trial of first-line therapy performed in South Africa, primarily in Black individuals. And persons who entered this trial were randomized to either dolutegravir with TAF-FTC or dolutegravir with TDF-FTC or efavirenz with TDF-FTC. Looking at the graph for men, this is male sex at birth on the left. You can see mean weight change here ranging from 1 to 5 kilograms over 96 weeks. You can see the most weight gain associated with dolutegravir plus FTC TAF. And you can get a sense that most of the weight gain occurs in that first 48 weeks, and then there tends to be a plateau. That has been consistent in most analyses to date, that the majority of the weight gain happens in the first 9 to 12 months after starting ART or switching ART. A few things, though, to highlight on the graph for women. This is female sex at birth on the right. Over 96 weeks, you can see here a larger overall mean weight change. Here, we're ranging from 3 to 10 kilos. So, 10 kilograms, we're getting up, this is a mean and there's a range, and some individuals gain more, some less. Here, we're starting to talk about 20 to 30 pounds or more. And you can imagine how that may change outcomes when we think about metabolic syndrome and other long-term complications. But really, I think what's notable here is, one, more weight gain in women compared to men when we don't fully understand why that is. And also in women here in this trial, even out to 96 weeks, we're not yet seeing that plateau. So later presentations on this data from ADVANCE highlighted that even at 96 weeks, in Black African women receiving first-line therapy, weight had not yet plateaued even at about the 2-year mark. And that's different than in a lot of other analyses. And again, I don't think we fully understand why. And these are things that we need to look into more. Now, this study presented at the International AIDS Conference in July, I think is really notable. So I'm going to highlight a couple of things here. So this cohort called OPERA looked at weight gain associated with various antiretroviral options in a large cohort of individuals, over 115,000. So this is individuals who switched from TDF to TAF, but maintained their anchor drug. So maintained an INSTI, NNRTI, or boosted PI. So this is narrowed to only switching TDF to TAF, not switching every antiretroviral in the regimen. I think there's a couple important things to note. So the timeline on the x-axis goes from 60 months before the TDF to TAF switch all the way out to 0. That's when the switch occurred, and then to 48 weeks after. And what you can see here before the switch, before time point 0, is everyone is slowly gaining some weight. That happens as we get older. It happens to me as much as I don't want to admit it. It happens to everyone. Everyone is slowly gaining weight. And then you can see time point 0, there's the TDF to TAF switch. There is then a fairly steep inflection point and then a leveling off or a stabilizing. The majority of the weight change happens in the 0 to 9 months after the switch. Again, these are individuals who maintained their anchor drug, so kept the same INSTI, NNRTI, or boosted PI. And you also can see in the orange box that those who were on an INSTI or NNRTI or PI, everyone gained weight for about that first 0 to 9 months and then leveled off. Looking at individuals who not only switched TDF to TAF, but also switched their anchor to an INSTI, to an integrated strand transfer inhibitor, either to boosted elbictegravir in the orange there, dolutegravir in the purple, or bictegravir in the pink. Again, you can see most of the weight change happens in the 0 to 9 months after the TDF to TAF switch, and you can get a sense here that more weight gain tends to occur if also switching to dolutegravir or bictegravir compared to boosted elbictegravir. Again, that's been pretty consistent in the data and analyses as well. So then I think that gives us a basis to show that yes, studies have consistently found an association between an integrase inhibitor, especially dolutegravir, bictegravir, and more weight gain than other classes, and an association between initiating TAF compared to other NRTIs or switching TDF to TAF as opposed to maintaining TDF or using other NRTIs. So we know there's an association. I think that's pretty consistent. I think that's pretty agreed upon. What we do not know, number one, is the mechanism, why that's happening. I'll tell you some of my conjectures, but I do not think we fully understand the mechanism. We do not fully understand long-term clinical consequences or metabolic outcomes. In that study we showed called ADVANCE, there were statistically higher incidence of obesity and metabolic syndrome in those receiving the dolutegravir TAF option compared to the others. So there's been some suggestion that it may change long-term outcomes or increase risk of metabolic syndrome and complications, but that data is much more inconsistent, and I don't think we know that for sure. And then we do not know the reversibility or really what is best to do if a person has gained an excess amount of weight on one of these antiretroviral regimens. So let's look at a couple studies that help us get at that, though I'm going to highlight some limitations. So first, looking at TANGO. So this is a RCT that looked at individuals suppressed on a traditional TAF-based regimen who were randomized to either continue that TAF-based regimen or switch to the 2-drug maintenance option of dolutegravir and lamivudine. So on the one hand, I think this could be really interesting and informative if what we had was dolutegravir with TAF FTC compared to switching to just dolutegravir 3TC, just removing the TAF. And we don't totally have that here. And the reason I say that is if you look at the breakdown of baseline regimens, if you look at the regimens people were taking when they entered the trial, it actually was mostly boosted elbictegravir, about 2/3, followed by rilpivirine and boosted PIs. There really was almost no one here taking dolutegravir or bictegravir. So really what we have here is an assessment of switching from boosted elbictegravir with TAF FTC to dolutegravir lamivudine. So we're going to get some data from this, but it's not ideal and not exactly what we need to help answer the question. And then here is just from, again, the AIDS 2020 conference in July, just the analysis looking at weight and metabolic outcomes. What you can see here is the overall weight gain, 0.81 kilograms with a switch to dolutegravir lamivudine compared to 0.76 with continued TAF-based ART. So really not a significant difference. You can see that looking at this, this measure or assessment of insulin resistance, that outcome did favor switching to dolutegravir lamivudine. There was no really clear winner in incidence of metabolic syndrome. However, again, I think that this is primarily a trial of switching boosted elbictegravir FTC TAF to dolutegravir lamivudine. So I really think we need to keep that in mind when assessing these outcomes. And I think what we can say is if someone's taking elbictegravir CoB FTC TAF and they're a good candidate to switch to dolutegravir lamivudine, they're viral load suppressed, no resistance, no hepatitis B, that's key, then I think we can expect some metabolic improvements. But what we don't know yet is if somebody's taking dolutegravir FTC TAF or bictegravir FTC TAF and they switch to dolutegravir lamivudine, basically they drop the TAF, what happens with weight and what happens with long-term metabolic consequences. So I hope we learn more about that in the future. The other question that has come up, and this has come up for me in clinic, this has come up talking to colleagues as well, if someone has had significant weight gain associated with integrase inhibitor FTC TAF, what happens with a switch, for example, to doravirine, the NRTI, and or a switch from TAF to TDF. So this trial, again, I think is very intriguing, but again, I'll highlight why I think it's limited in adding to our understanding. And again, I think that is because of the baseline regimens individuals were taking. So this is a an RCT of individuals suppressed on more traditional sort of 3-drug therapy, who then were randomized to either continue the 3-drug therapy or switch to the more newly approved doravirine 3TC TDF combination. You can see there was an immediate switch group and then a group who switched on a more delayed manner. And importantly highlighted here, the baseline regimens were primarily boosted PIs, with a small number taking NNRTIs and a very small number taking boosted INSTI, basically cobicistat elbictegravir. Really no one here taking dolutegravir or bictegravir. So again, this is primarily a study of switching boosted PI to doravirine 3TC TDF. And what we can see, acknowledging that, is that comparing the two groups, those who either immediately switched to doravirine 3TC TDF or continued their first-line regimen, again, mostly a boosted PI, weight change after the switch was not significantly different in the immediate and switch group, and does look more modest here than in those who switch, for example, to dolutegravir or to TAF. So again, I think that this regimen, doravirine 3TC TDF, there's some suggestion here that maybe it's less associated with weight gain or less likely to lead to weight gain, but I think we really have some limitations here in these analyses, and this leads to questions that we're really going to want to answer in the future, and I'll come back to a way that we are going to try to get better answer to that question. First, this abstract I think also is very notable. This is from Grace McComsey and colleagues, just presented very recently at ID Week, and I think this was a really very clever question that they asked. They asked, well, if TDF to TAF is associated with weight gain, how about abacavir to TAF? Really trying to get at the question, well, is it the TAF that's causing the issue? Is it that we're adding this new drug that might be stimulating appetite or, might be leading to weight gain as some sort of not fully understood side effect? Or is it the TDF has actually been suppressing the weight gain and then we pull off the TDF and switch to TAF? Maybe that was the issue. Maybe the TDF was actually leading to more appetite suppression and weight loss than we anticipated. So the question here, if TDF to TAF leads to weight gain, how about abacavir to TAF? Does that have the same effect? So is it the TAF or not? Those who switched abacavir to TAF in the dark bluish bar, and those who switched TDF to TAF in the orange bar, broken down by those who gained more than 3% body weight, more than 5%, or more than 10%. And you can see here in each of those categories, those who switched TDF to TAF gained more, or there were more individuals in those categories of weight gain than those who switched abacavir to TAF, suggesting, I think, that maybe it's not the TAF, maybe it's actually that TDF has more of a weight suppressing effect, and when we pull it off or switch, those individuals are more likely to gain weight for that reason. Those factors associated with more than 3% body weight gain in the year post-switch, the statistically significant factors being TDF to TAF compared to abacavir to TAF, baseline BMI underweight compared to overweight or compared to obese, CD4 count below 200, and then in this trial, female sex at birth associated with more weight gain than male sex at birth, and in this trial, the other demographic factors there not statistically significant. Looking at the Gemini 1 and 2 studies, these were trials for treatment-naive individuals randomized to either dolutegravir TDF FTC or dolutegravir plus 3TC, the 2-drug regimen option. And I think notably here, you can see that mean weight change from baseline to week 144 was higher with dolutegravir 3TC compared to dolutegravir FTC TDF. The reason I think this is notable is this does give us a comparison of the same anchor drug dolutegravir, with 3TC or FTC, and then either with or without TDF. So we really can get at, okay, what's the effect of TDF? And the fact that individuals receiving TDF gain less weight, I think, is a suggestion that perhaps the mechanism or issue here is TDF suppressing weight more than we realized, as opposed to some new indirect side effect of TAF or of the newer agents. But again, I think we need to understand more. So what did the guidelines say? The guidelines in the United States, both guidelines group have updated their language and really have said that we know that weight gain is associated with certain antiretrovirals. We do not yet know why. We do not yet know the reversibility or what to do about it, but we should be counseling everyone about the potential for weight gain, giving information about lifestyle changes and behavioral modifications, and really monitoring closely for weight change and for adverse metabolic outcomes. So points for discussion, points for thought. Would love to hear what you think. So does potential weight gain impact your recommendation for first-line ART? For me, I will just say that it has not. And I think we have to weigh what we know and what we're learning with the outstanding questions, and also with potential benefits for drugs like bictegravir and dolutegravir, which have very high barrier to resistance, which tend to have fewer drug-drug interactions than some other options, and for many individuals are relatively well tolerated, not for everyone. What this has impacted, though, is counseling about the potential for weight gain has become a routine for me when advising individuals who are starting their first ever ART regimen or when switching. So I have certainly added that into my routine. I have also seen rare individuals who it does seem like have gained substantial weight while taking either one of the integrase inhibitors or TAF, for example, after a switch. And I do explain what we know and what we don't know and all the outstanding questions. And there have been rare instances in which I have advised a switch, but it really has not been routine. It has been really rare instances. So I will leave that as food for thought. Again, I think we're going to learn a lot more about this in the new future and hopefully learn more about how best to address this and about the long-term risks. So these are the key take-home points. I think I've made most of these points clear, so I won't go through them in detail. I think most importantly, I think the mechanism of antiretroviral-associated weight gain that is different between agents or classes remains to be determined. I think it is unclear if dolutegravir or TAF are in some way changing hormones, stimulating appetite, leading to more calorie intake, leading to weight gain in some indirect off-target way, or if what we're seeing is actually the drugs we were using previously, the TDF, the efavirenz, were suppressing weight, were affecting the mitochondria, were suppressing appetite more than we realized. And what I've seen in recent data is really suggestive that that is probably more likely than some new off-target effect of the INSTIs or TAF. We just don't know yet. The other thing we really don't know for sure yet is when individuals gain weight on these various drugs or classes, what is the composition or breakdown of that weight? Is it subcutaneous? Is it visceral? The visceral or mesenteric adipose deposits being much more likely to lead to long-term metabolic outcomes. The data I have seen on that is much more mixed, and I think we really need a better understanding of that. I have seen data showing that it's really a mix of subcutaneous and visceral adipose tissue. There was just a presentation at one of the recent conferences that actually showed that it was actually much more subcutaneous than visceral, but I really think we need a better understanding of that, of the long-term outcomes, and about what to do about it. And in the meantime, I think very important to counsel about this potential and help individuals choose the best ART that makes sense for them. And if they seem to be developing adverse consequences of the weight gain over time on ART, discussing what we know and don't, and the potential pros and cons of an ARV switch. This will be a slightly quicker topic, but also a topic of much interest in the last year or two. I think many of you know the big question has become, well, does dolutegravir increase risk of neural tube defects or not? We've had some really important updates on that recently, so that's what we're going to focus on, really safety of dolutegravir compared to other options, and then safety of TAF in pregnancy, which we are starting to learn about. This is just a reminder from the Department of Health and Human Services guidelines. Dolutegravir is a preferred option in pregnancy regardless of trimester. It is still listed as recommended for an individual's childbearing potential who is using effective contraception, but an alternative if not using contraception routinely, if may conceive, or if trying to conceive. But the caveat to that is these guidelines have not yet been updated since we got the most recent results from the SEPAMO study of dolutegravir and neural tube defects, which we will show you. So this is a reminder of, again, most recent Department of Health and Human Services guidelines for ART in pregnancy, again, not updated yet to incorporate most recent data on dolutegravir or most recent data on TAF in pregnancy. A reminder of the NRTIs on the left here, recommended as first line during pregnancy. The integrase inhibitors, raltegravir BID, not the once daily high dose in pregnancy because it hasn't been studied yet. Dolutegravir, the boosted PIs that are considered effective, safe options, boosted azanavir or boosted darunavir. Per guidelines, boosted darunavir should be BID in pregnancy because of lower levels as pregnancy gets into the later trimesters. And then not recommended because of insufficient data, including TAF, bictegravir, and other newer agents like doravirine. And then importantly, just an important clinical reminder, cobicistat as a booster not recommended during pregnancy because of data that levels of the antiretrovirals decrease, again, especially getting into the second and third trimesters. So that's a reminder. Again, those guidelines not yet updated with the most recent dolutegravir neural tube defect analysis. Let's look at that. So this, I'm sure many of you are familiar with, lots of news from it over the last 2 years, lots of practice changing based on these results. So this large birth outcome surveillance study in Botswana, initially designed to look at adverse outcomes from efavirenz, but then Botswana was the first country in sub-Saharan Africa to roll out dolutegravir and started surveilling for adverse outcomes from dolutegravir or efavirenz and other ARV options. And what initially made big waves and headlines, and really I think was practice changing, was this assessment here in the first line that with dolutegravir, the estimate of neural tube defects when taking at time of conception was 0.94% compared to 0.12% with non-dolutegravir ART, most of which was efavirenz. That was the initial interim analysis result that we saw, and based on that, I think a lot of people did steer away from dolutegravir for individuals who might conceive or want to conceive. I know in my practice, I ended up changing a lot of ART because there was this very significant concern. And then what's happened is as this study group has accumulated more participants, more numbers, more outcomes data, what we've seen with each update is that estimate of neural tube defects from dolutegravir has decreased. You can see here, prior to this July at the AIDS conference, what we knew was a updated estimate of 0.3% with dolutegravir compared to 0.1% with non-dolutegravir, again, mostly efavirenz. Still a statistically significant difference, but the overall difference coming down as more data accumulated. And then importantly, this is the most recent update we saw July 2020. And what you can see here, their analysis from April 2020, so that's the most recent we have. Here, 0.19 with dolutegravir compared to 0.11 with non-dolutegravir, a difference that is no longer statistically significant. Again, as more data has accumulated, it seems like the risk of neural tube defect with dolutegravir taken at time of conception is not higher than with other ARVs. Again, in this study, primarily efavirenz is the other ARV that was assessed. It does not seem to be higher. So a lot of reassurance. And then the other thing we saw, and I think this is very notable, is the first data for TAF during pregnancy. So this study called Impact 2010, that's the study number, not the year it was done, looked at the safety and efficacy of dolutegravir with TDF-FTC or dolutegravir with TAF-FTC or efavirenz with TDF-FTC, started at 14 weeks or later during pregnancy. So importantly, not started in the first trimester. We don't yet have any data on TAF in the first trimester, but started in the second trimester or later. You can see some notable things here. Dolutegravir compared to efavirenz, comparing the rates of viral less than 200 delivery. Dolutegravir was the winner over efavirenz. And then looking at adverse pregnancy outcomes, dolutegravir with FTC TAF appeared to be the winner. Also looking at preterm delivery, the lowest rate was with dolutegravir FTC TAF, and there was no statistically significant difference for small for gestational age or stillbirth, but some suggestion that, again, when started at 14 weeks or later, dolutegravir FTC TAF may be the safest option. Now, coming back to our prior discussion, there was an association with greater mean weekly weight gain in those women who took dolutegravir FTC TAF during pregnancy compared to the other options. You can see here the dotted line is really recommended weight gain during pregnancy, and all three of these groups did not meet that recommendation. So I do not think we fully understand why that is, and I think this is another area where we need more study and more data and guidance. Now, this is a separate analysis, a meta-analysis that really combined data from large trials to get back at that question of dolutegravir versus efavirenz during pregnancy. You can see on the far left that, again, and I think this has been pretty consistent, dolutegravir during pregnancy leads to a higher rate of suppressed viral load at time of delivery. The actual mother-to-child transmissions here were not statistically different, but they were so rare, it's such a rare outcome that I don't think we would anticipate them to be different. But I think there's a lot of suggestion and support here that dolutegravir during pregnancy is effective and is a favored option to achieve viral suppression at time of delivery. So a couple of discussion points, and then we'll turn to questions and discussion. So based on the latest APAMO data, what would be your recommendation for a woman suppressed on dolutegravir who wishes to conceive? I think that the updated data is very reassuring that dolutegravir taken at time of conception does not increase risk of neural tube defects compared to efavirenz. I would counsel a woman about what we know, what we don't know about that latest data. If the person were doing really well with suppressed viral load and preferred to stay on that option, I would support that. The one thing I would add is I really would encourage folate supplementation to reduce any likelihood of neural tube defect at all, but I would support it. This, I think, is a little trickier question. If a woman becomes pregnant while taking TAF, would you recommend a switch? So in the package insert and the guidelines, again, still insufficient data for TAF in pregnancy. As I showed you, we now have, I think, very reassuring data about TAF use in second or third trimester, but we do not have data for TAF in the first trimester. So again, I think this becomes a one-on-one decision, some shared decision-making about what we know and what we don't know. And if this were a person who had been taking TAF for a very long time, suppressed viral load, tolerating it, taking it with an anchor drug of, it's rather potent with a hybrid resistance like dolutegravir, I would not say the person has to switch and would support staying on it. If this were someone who had more recently started, had no reason not to switch to TDF, wasn't taking a very potent anchor drug, I might be more conservative and switch to TDF. I would make sure that the person is not taking something known to be ineffective, less effective, or less safe in pregnancy, like a boosted L-vititegravir. I recommend all women switch off of that when trying to get pregnant or when become pregnant. But as long as it were not something we know to be less effective or know to be unsafe, then I do think a lot of people who are taking their regimen prefer to stay on their same regimen. And if they're doing well, I would support that. And I hope that I have stressed these key take-home points. Most recent data reassuring about dolutegravir and neural tube defects. Dolutegravir does seem to lead to a higher likelihood of viral suppression of efavirenz over time. TAF appears to be safe and potentially advantageous compared to TDF, but we only have data when started second trimester or later.
Thank you very much, Dr. Wood, and thanks to our listeners. As a reminder, to view the full educational program, What's New in Antiretroviral Safety and Tolerability, Implications for Treatment, on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thanks!